Good morning, I'm Karlee Lau. I'm one of the graduating chiefs. Today I'll be talking to you about post-op ice use. Some of you know me as thing one. Hold on. Okay, much better. Just trying to break the ice. Okay, no more bad puns. Maybe just a little bit more emojis. But really, I'm going to talk to you about my research project, the effectiveness of cryotherapy over plaster splints after hand and wrist surgery on reducing pain and skin temperature. Dr. Maraki is my PI. So we've all used ice, and I skipped over one part, but we've all used ice. We all are familiar with RICE. We prescribed ice for fractures, post-operative wounds. We've put on a cryo cuff on our patients. Cryotherapy is proposed to lower your skin temperature, decrease tissue, blood flow, pain, and metabolism. And how it does this is by alternating between vasoconstriction and vasodilation, thereby bringing reparative cytokines into our area of injury. And it also slows down the neuroconductive velocity to control pain. But best of all, it's cheap, fast, and easy. So how could it be bad? Recent research have shown that ice can inhibit essential parts of the inflammatory cascade like macrophages, transforming growth factors and insulin-like growth factors that can impede healing. There has also been case reports of skin complications like frostbite and skin necrosis from prolonged application. So it's important to determine the parameters in which these adverse effects can occur so we can minimize these complications. There's been a lot of mixed studies on its efficacy postoperatively, even though ice has been used for a very long time, but the use is mostly based on anecdotal experience, and the effect on patient outcomes is poorly understood. Some studies did not find any statistical difference on skin temperature, pain relief, or functional outcomes using ice, either after injuries or postoperatively. While other studies have shown promising conclusions of reduced pain and swelling, improved mobilization, and that it's safe to use. But a lot of these studies have very small patient population. Also, they combine ice with other treatment modalities such as compression, elevation, or different various ways of delivering the ice or how long the ice is applied. We can't gather a very specific conclusion from their recommendations. So we're still unsure whether or not it's doing anything, but we prescribe it because we've always prescribed it. That's the only time I can use a picture like that, so I had to do it. But what? Google has a lot of, yes. So what do we actually know about ice is that it can penetrate through plaster and synthetic dressings. In a mannequin study that was performed at this institution, ice decreases the amount of heat energy experienced by the arm immediately after splinting and continues to be effective over 2.5 hours after application. But there's still a lot that we don't know, such as how long should we have the ice on the extremity? What is the best way to deliver our cryotherapy? How do we quantify whether or not it's actually effective? And we don't have an evidence-based protocol to balance between maximizing its benefits and minimizing any adverse effects. So with the current concerns of rising healthcare costs and narcotic epidemic, physicians must prioritize delivering effective and high-quality healthcare while balancing costs and maintaining patient satisfaction. ICE can potentially play an important role in achieving these goals as part of a multimodal therapy for acute injuries. So again, this is a stepping stone to establishing a evidence-based protocol for applying cryotherapy. What we're looking at is comparing two groups, one ICE group and one without ICE, and looking at a few parameters. One thing is pain relief and using the visual analog scale, and also measuring the narcotic analgesic medicine used postoperatively. Other parameters we're looking at are the amount of heat exposure of the skin under the plaster splint in patients undergoing fracture repair, and also looking at the average, maximum, and minimum skin temperature in each of these groups. Our null hypothesis is that ice will have no significant reduction in the immediate post-op pain as measured by the VAS, and no reduction in narcotic administration. However, in our mannequin pilot study, the average difference in energy absorbed under the plaster splint between cryotherapy and control group was clinically or statistically significant. So based on these results, we've hypothesized that there will be a significant reduction in skin temperature range and total heat exposure when applied over plaster splints in our human subjects. This is an IRB-approved, prospective, randomized, controlled, and blinded study, blinded to the best of our abilities. And I'll go into that more in our methods section. So we've determined from our power analysis that at least 128 patients are needed in total for this study, 64 in each arm. And how we're recruiting these people are the indicated patients in our clinics who are seeing our attendings, fellows, or residents for ambulatory wrist and hand surgery that will be performed as a day surgery at OHSU CHH ORs. So they will be these surgeries will be performed by Dr. Morarki or Dr. Nazir, and these people will require post-op wrist or thumb spica splints. Patients who will not be included will be those who are not amenable to splinting, if they have skin damage, peripheral vascular disease, or will be admitted to the hospital. Pregnant women, prisoners, minors, people who can't consent are also excluded. In our pain analysis portion of the study, anybody who receives a peripheral nerve block will also be excluded from that portion. So we have a wonderful research assistant who comes in at the conclusion of the operation before the dressings are on and helps put on sterile temperature probes on both the volar and the dorsal side of the wrist adjacent to the incision. And then a standardized splint will be put on by either the attending and or resident fellow. The patient is then randomized to either the ice or the control group, and based on what that is, they'll be given an ice pack filled with either ice or rocks. And we use a standardized 200-gram ice pack. All the forearms are placed in neutral position so that we're not adding another factor such as elevation to our study. And we start the data logger in the OR and get the two first readings for baseline. This data logger will log every 1 minute, and once they're in the PACU, the nurses will continue their standard post-op assessment with recording of the VAS every 5 minutes, and accordingly giving narcotic medication if indicated. All of this will be recorded in Epic. We continue this data collection for 60 minutes or until the patient discharges, if that's before the 60-minute is up. So again, we determined 128 patients are needed in order to adequately power our study to get a change in VAS score of 5 and a difference in the narcotic requirement, 2.5 milligrams. A simple t-test is used to evaluate the differences between the two groups, looking at maximum, minimum, average temperature, and also the calculated total thermal energy exposure, which is calculated using area under the curve. Once we have more patients in our preliminary results, we'll do the analysis within each procedure subgroup in order to reduce confounding bias. So in total, to this point, we have 44 patients, and that's not exactly updated from the paper that we submitted to Dr. Ladd. I've since added more patients. So 44 patients, 21 in the ICE group, 23 in the no ICE group. 13 of these people did not receive a peripheral nerve block, 9 of them in the ICE group, 4 in the control group. Looking at the pain parameters, in the ICE group, the mean change in VAS score was 2, and the mean oral morphine equivalent dose was 2.97 milligrams in the PACU. And comparing to the control group, the mean change in VAS score was 1, and the mean oral morphine equivalent dose was 3.48, and this is further illustrated in this chart. One thing you might notice is that the mean VAS score for the control group is 0 versus a 2 for the experimental group, and there was a patient who complained of 10 out of 10 pain in the experimental group, and it kind of skewed the numbers a little bit. And also, you have to keep in mind, this is based on 13 people, so this may shift once we have more patients enrolled. Looking at the skin temperature parameters, the ICE group had a lower overall skin temperature compared to the control group, both on the splinted and non-splinted sides. It also reached a lower maximum temperature on both the splinted and non-splinted sides, and this was statistically significant. The ICE group also reached the baseline temperature on average about 55 minutes after the splint was applied, but the controls never reached the baseline temperature within the hour that they were here. The heat exposure difference was 15.49 calories between the two groups, although not statistically significant. The control have 40 calories versus ICE have 15. There is an appreciable difference between the two. And the nitty-gritty numbers are printed on here. So there are some limitations to this study. We understand that each procedure has different level of invasiveness and has different post-operative pain. Upon tallying our surgeons' practice, the most popular procedures are ORIF of distal radius, CMC arthroplasty, and wrist scopes. So statistic analysis will be performed within those subgroups to further get rid of any confounders. Also, patients receiving peripheral nerve blocks will not have useful pain parameters, so we will need a larger patient population for that portion. We have started to give everyone local anesthesia near their incision at the end of the surgery. This is according to the anesthesia task force, that this is a very useful multimodal adjunct to pain control, and we have found that our patients have better pain control with that. So in order to make everything the same, those people not receiving nerve blocks also get local anesthetic near their incisions. Some of the strengths of this study is that it is prospective, it's randomized, controlled, and blinded to the best of our abilities, so the surgeon doesn't know what they're going to be randomized to, and we don't really interact with them once the ice is put on their limb, and the patient really only gets to see that a similar ice bag is put on. They don't know if it's ice in there or it's just rocks in there. And it is the first study to really look at ice alone, not combined with other types of therapy like elevation or compression, and doing this over a standardized splinting. There's been some research showing that gender or age does play a role in pain perception and pain control. So all of that is included into our database, Minds from EPIC, and we'll do an analysis to make sure that the two groups have equal demographics. Some of the conclusions that we're drawing right now is we still need a lot more patients in order to make sense of what's going on with our pain parameters. But we are seeing that the ICE group is experiencing a lower temperature range compared to the control group. So far, we found that there is statistical difference between the maximum temperature that's reached between the two groups. And also, even though it's not statistically significant, the cryotherapy group has a relatively less total energy exposure compared to the control group. And so the use of cryotherapy after injury and surgery has long been used, but the effects of that is poorly understood. we're hoping to establish an evidence-based protocol that specifies cryotherapy delivery modes and application duration in order to maximize its benefits as a treatment modality. This has been presented as an eye poster last year, and we're looking forward to giving you some updates this year in Boston. Thank you to our research assistant, PI, Dr. Markey, Dr. Nazir, Marie Kane for looking over my manuscript, and also research committee for all of the very helpful comments. And thank you for Dr. Ladd for coming out and your simulation lab demonstration yesterday, and all of the attendings who came onto the boat yesterday, Dr. Rafali, Dr. Rainey, and Dr. Brady, and for pedaling when all the residents, by residents I mean Derek, who got tired at the end. Yes.
Okay. First of all, how many in the audience know who Vanilla Ice is? I was wondering who that told. So thank you, Karlee. Thanks for sharing with you and Dr. Meraki and Dr. Nazir and your work to date. And you answered a lot of my questions in the presentation, but I'll address them anyway. One was limiting the procedures. So you are going to now limit to distal radius fracture, CMC arthroplasty, and wrist arthroscopy. I think that's...
Yeah, it's very hard to quantify exactly how, you can't say a de Quervain is the same pain as a CMC arthroplasty or distal radius, and we realize that. So we're going to do the analysis in subgroups once we get a lot more patients. The only caveat is it might require even higher number of patient pool in order to really successfully power that part of the analysis. But we also don't want to make the study period longer than it needs to be. So it's kind of a balance between making sure we have enough to actually find a difference, if there is a difference, versus having a study that requires thousands and thousands of patients.
Well, the problem is you're getting into confounding variables, and so you've eliminated some of them. Like it sounds like going forward you're going to do local anesthetic for all procedures. I think that's good. What I'm saying is I think you can tighten up your criteria so you stay on track to answer the questions. So I think CMC and distal radius fractures are ideal. I'm not sure wrist arthroscopy teases out as much kind of pain level, but I don't know. You probably have some sense with the VIS so far. But the local and all individuals, and you might consider looking at your time point at something like 72 hours, because the ice is only there for temporary. But looking at opiate consumption and the pain scale at a time point where we know swelling has been maximum and ideally is beginning to taper, because that might tease out some really robust information. And I tell you that in the face of, so we have an anesthesia team who loves to do blocks and love to do indwelling catheters, and we're fighting them because they have no support afterwards. And they say it takes less pain medication. Well, it turns out they take no difference in the amount of opiates whether they have a indwelling catheter or not. So they're kind of not proving the point of what they said. So for you guys, maybe there's something really critical at that first couple of hours of ice that will reflect on their amount of swelling and pain a couple days out.
So we're looking at ice application for ambulatory surgery, and it's also been brought up before, maybe we should track these patients' response and how much narcotics they're taking even after they leave the hospital. The only thing is it's very difficult to standardize the way that the ice is applied once they leave the PACU, and then also tracking exactly how much pain that they're having once they get home. All of that would have to be patient survey, and when they come back in 2 weeks, it's hard to know if they remember exactly how much they've taken. So I think we were trying to make our study a little more focused, and everything should be, that can be controlled, then we'll try to control it, which is easier while they're in PACU, within that first hour.
Got it.
Everything is standardized, the splint, the dressing, how the ice is applied is standardized. Like the VAS score that we get, the narcotics, there's no one saying, no one not remembering exactly how much they took. It's all in Epic. But we have thought about, maybe we should extend our recording. But that would I think it would be very hard to get rid of that bias, because we can't be for sure how the ice is applied and how much pain medicine each person is taking.
Oh, great start. Great start. Look forward to seeing the next phase.
Thank you.